All right, I got recording started, so.
Okay, all right. So I see a few people here that sort of were not on the rotation. So I'm just gonna kind of introduce who we had this block. So Mike and I, for those of you that don't know, we are two general internists. We just finished our GIM training last year. We did 6 months of ultrasound fellowship in the ICU with Dr. Robert Arnfield. And as part of our initiatives, we started offering POCUS elective at Victoria Hospital. Now this elective, or selective I should say now actually, existed at university for the last few years under Dr. Jeffrey Yu. And so we just sort of expanded our offerings a bit. And so it's a very popular selective. And so we could sort of now take on more learners that are interested and excited about learning ultrasound. So this month we had two PGY3 Internal Medicine residents, Jennifer DCruz and Kathleen Winger. Jen is doing respirology next year. Kathleen is doing GIM. And I think they both came to us with, I would say probably limited experience, but I think, I probably speak for myself and Mike here when I say that we're quite happy and proud of the way they sort of progressed through the sort of few weeks. And towards the end, they were doing pretty advanced things that I would not have expected them to be doing. So I hope that they were able to take a lot out of this sort of 4-week block and sort of take it on to sort of their practice next year. So they have both put together some cool presentations, some interesting cases for us to go through, and for those of you that are interested in ultrasound education and learning. So without further ado, Jen, why don't you take it away?
Yeah, thanks so much, Zane, for that kind introduction. So yeah, as he mentioned, I'm Jennifer DCruz, PGY3 resident, and definitely had excellent teaching on this rotation. Both Mike and Zane did a fantastic job. And for any resident watching this presentation, would highly recommend taking this as a selective for sure. So as I'm interested in respirology and will be pursuing it next year, I was very interested in seeing how we can take it one step ahead of going beyond a chest x-ray, which is very routinely ordered, and how we can use lung ultrasounds to help shed light, hopefully, on your assessments and plans. And so I was hoping to go through some case presentations. So I will start off first with going through what are the 4 main lung viewpoints, through which we use our phased array probe, try to highlight some of the features of pneumonia that you might expect to see on an ultrasound, try to point out sort of what a complex pleural effusion might look like, and then conclude with some of the limitations that we have to understand when using an ultrasound, but also what are some of the advantages of it as well. So getting started off on our viewpoints. So there are 4 main viewpoints on our hemithorax. We start off with R1, which is sort of the mid-clavicular line at the second intercostal space, then R2, where we're going ahead to the sort of the anterior axillary line around the line of the nipple. And together, these 2 viewpoints provide information about the parenchyma of the lung, where you can comment on things like lung sliding, A lines and B lines, which I will allude to later on as well. And then moving on to R3, where now we're going to the mid-axillary line of costophrenic angle. And then lastly, R4, which is often called as the clasp point. And this is where it's the extremely dependent region of the lung, and it has a very high sensitivity for detecting consolidations as well as effusions. And so this is exactly sort of a picture as to where you can find that clasp point. And so these annotations R1, L1 are what I will be using, and you will see in all of the clips moving forward to help you orient as to where we're looking at within sort of the chest hemithorax. So starting off with our first case presentation, so we have a 68-year-old female with prior carcinoid tumor of the right lung. She's had a prior right middle lobectomy in 2017, presented with acute onset dyspnea and sudden pleuritic chest pain. Her CTPA showed that she had moderate burden of PE in the left segmental arteries, no heart strain, and despite being on anticoagulation treatment, she was having increasing O2 requirements, as well as some new cough, sputum production, and also had went into a rapid atrial fibrillation. And on day 5, so you can see day 1 and day 5's chest X-ray. And at the point when we sort of were advised to come and see her, she was on 6 liters nasal prong, satting 90%. And really the question here was, is the cause of this persistent hypoxemia due to the PE alone, or is there perhaps some other new etiology that might be explaining her symptoms? And so let's take a look at her actual ultrasounds as well. So right here at the top, we're looking at the lung apices. And so just for those who may not be as familiar, so what we're looking here right at the top, kind of is called the lung sliding, sort of the shimmering effect, where you're seeing the visceral and the parietal pleura kind of sliding against each other with every sort of inspiration and expiration. And then here, what is sort of clear is what we call A lines, which are basically just horizontal reverberation artifacts that are equidistant from each other and usually tend to annotate sort of a more normal or a healthier parenchyma, which is unlike what we see here down here at L2, where you can see some of these beams, which kind of look like flashlight beams, which are called B lines, which are vertical artifacts originating from the pleura. They tend to obliterate the B line and they extend all the way to the bottom of the screen. And you can also see here some minor irregularities in the pleura, looks a little bit thickened. And so moving on then, going more towards sort of the bases, costophrenic angles of the lungs itself. Here on the right side, you can see maybe a bit of a tiny effusion, but what is really more prominent is on the left side, where we can see sort of a small to moderate sized effusions. And the arrow pointing here is a shred sign, which I will allude to a little bit more about. So very sort of unilateral findings. So putting all those clips together, what we see are B lines bibasal with smooth pleura at the apices and thickened pleura at the left mid-lower region with a positive shred sign at the left base. Changes noted within the left lung are concerning for an underlying infectious process. There was a small to moderate left-sided pleural effusion with associated consolidation, and the unilateral nature of this kind of raises the possibility of possible infection. And so when you put this into a clinical context, so this patient had an elevated white blood cell count, she was afebrile, but was having increased cough and sputum production, and actually a sputum culture then ended up growing Pseudomonas aeruginosa and was treated with piptazo. And you can see this just a day later when we look at a chest X-ray. Now you can start to see sort of more prominent findings on the left side, which we weren't seeing as much of earlier. And so some of the takeaways really from this point is the X-ray that we had initially seen, we didn't really see the amount of fluid that we saw on the ultrasound imaging. And so actually ultrasounds can detect up to like 20 cc's of fluid in the pleural space, whereas chest X-rays may not reliably pick up less than 100 cc's of fluid on an AP film. And so this is just a meta-analysis that was done in 2016, where the pooled sensitivities and specificities were found to be a lot higher in the detection of pleural fluid when looking at ultrasound. So 94% sensitivity versus 51 on an X-ray, and a specificity of 98 versus 91. Other takeaway was, what are some features of pneumonia that we might expect to see on an ultrasound? So we are very familiar of consolidations affecting the entire lobe, but when you're looking at the anterior chest wall specifically, there can often be sort of a spectrum of what you can expect to find, where you can see a area of hypoechoicity region under the pleura, where as the consolidation tends to get larger, you can start seeing an interface between non-aerated lung versus aerated lung right over there, and that creates a very sort of a fractal or irregular border, which is then considered the shred sign, and it's a sign of a non-translobar consolidation. Other features we may see is evidence of reduced lung sliding sometimes in a very severe case, or in this case, what we're seeing is just appreciating the pleura itself. So here at the bottom, we see a very sort of a smooth, thin pleura, whereas here on the right side, we're seeing sort of appreciating more of a thicker pleura, a little bit more irregular looking, which you may see, it's not pathognomonic for an infection per se, but it could just mean that there's something else going on and sort of makes you think about what else might be there. And then other sort of features of a pneumonia. So here on the left here, we have what's a very normal, healthy looking lung. So we are seeing here liver, the diaphragm. And so with inspiration, you can see the lung kind of sliding in and out. And that's what like sort of a normal, healthy looking lung should look like. And that's called the curtain sign. On the right side, however, what we're seeing here, again, liver, diaphragm, but you see a very densely consolidated lung there. And what we can also start appreciating here, and if you can appreciate sort of the little movements in and out, and that's essentially what we call dynamic air bronchogram. So it's a hypoechoic sort of linear punctate opacity that moves with inspiration. And this is considered to be very sort of pathognomonic for a pneumonia and has a specificity of 94% and a positive predictive value of 97%. So that's sort of very interesting information that I had not known of before. So then moving on to case presentation 2. So now that we know what a pneumonia looks like, let's see this gentleman. He's a 63-year-old male, end-stage renal disease, secondary to polycystic kidney disease on intermittent hemodialysis, was on treatment for a MSSA perm-cat line infection and was transferred over from a tertiary hospital because he was having intermittent periods of hypertension. And so that was delaying him receiving dialysis. And so he didn't have any clear respiratory or infectious symptoms. And so the nephrology team had already initiated a hypotension workup, but the chest X-ray had mentioned a likely small loculated effusion on the right side. And so that got us thinking, well, is there really a loculated effusion? And so we went on and a ultrasound. And then so here, what we're seeing on the apices, you can start seeing that there's clearly A lines, but maybe a bit of B lines also kind of coming through, especially here on R1. And then looking here at R2, you can appreciate a lot more sort of B lines. And then moving down, here's where sort of the significant change you can see is on the right costophrenic angle. You can appreciate that there is a pretty moderate to sort of large sized effusion that can be appreciated, but again, no features to suggest that this was complex looking. And so what we concluded here, and to basically help answer that question, was a moderate to large sized effusion that was simple in appearance. And so the takeaway here is, one, not only did the POCUS allow us to be able to, with a quick probe by the chest, help identify that this is not complex looking. So it avoided a CT scan, but of course you have to put everything within clinical context, the fact that he was stable and did not have any infectious symptoms. So you have to put everything together. But it also begs the question, well, what would have a complex effusion look like? And so this is an example here of another patient which we had POCUSed, and it was for the same question, is there a loculated effusion? And so this one is definitely a more complex looking effusion where you can see lots of fibrous strands over here, as well as at the bottom here, what's called a plankton sign, where you can see sort of hypoechoic debris within the pleura itself, which would have been visible and if you kind of turn down your gain as well. And so this is just another image of where you can see this sort of debris within the pleura as well, and as well appreciating the septae that you can see in a complex sort of exudative effusion. So that was a takeaway from that case. Moving on to the next one.
Yeah, and sorry to interrupt you. It's Mike. Do you want to go back to the images at the base of this case?
This one here?
Yeah, right here. Yeah. Just, before we kind of move on to other cases and things,
of course.
I think the other thing that's important to mention here is that, we often talk about main kind of points, main areas of the lung that we want to image to rule out pathology. But if you're looking and you do find pathology, what else would you do with these images? Like, what else would you do when you see this effusion? Would you just, and I'll ask you, Jen, would you just click these and move on?
Oh, for me, myself? Yeah, no.
Yeah.
So what I've been doing, at least, and me and both Kathleen, and in discussion with yourself and Zane, is we always take these clips and we put them into clinical context, and we actually let the team know right away as well, so that we can try to determine, is it pointing more infectious? Is it more fluid overloaded? And so provide recommendations based on that. So in this,
but more so, what I'm kind of getting at is, if you see any kind of pathology, do you just stop with that clip? or do you go on and try and get further information with the ultrasound?
I would try to go and get some further information just to make sure that, you know, you what you're thinking about is really the right thing and that there's nothing else that you might be missing.
Yeah, and so the one thing that I would point out here is that, especially in this clip on the bottom, kind of the plaque point or the base here, is that we don't see the lung very well. We might see a teeny bit of it, which could be because we are aiming so posteriorly that we're no longer seeing lung in the effusion, or it could be because the effusion is so large.
Yeah.
And if the question is to assess for a loculated effusion, I think it's really important to make sure you slide all the way up and follow this effusion. If the patient can sit forward for you, that's great. You can, you know, look posteriorly. But otherwise, try to follow this effusion up, because you'll sometimes find that, you know, loculated effusions don't have to be extremely complex. And so I think this is an important point, is that if you see complexity, like Jen mentioned, with fibrin and with plankton sign and all of that, then that's a complex effusion. But there are times where it may appear to be a simple effusion. That does not mean that you might not have an exudate, or you might not be catching something that's a bit more apically oriented. And so I just want, you know, everyone who's here to be aware of that. Sorry to interrupt. Keep going.
No, that's perfect. Yeah, thanks for making that point, Mike. That's really important. All right, so then the next piece 3 then. So we have an 85-year-old female with type 2 diabetes, CKD, and hypertension who had presented with dyspnea, orthopnea, PND, known HFpEF in the context of a recently treated as well pneumonia infection, and now came in with an acute on chronic CKD. So the team was managing her by diuresing her with ADIV, BID of Lasix, and they had also optimized her cardiac medications. So on the left, you see a chest X-ray that was done at the time of admission, and then 7 days later is a chest X-ray that was then repeated after being on diuretics, essentially. And so I'll let you kind of interpret that image as to, do you think that there is an improvement in the chest X-ray? Not so much, or perhaps you want some more information to help you decide on that. So from our perspective, when we were looking at the ultrasound itself, starting all the clips here. So you can see that on the left-hand side is the images before diuretics, and on the right side is after getting diuretics, again, 7 days later. And so what I appreciated really just right off the bat is, you know, definitely a lot of B lines, but the amount of B lines that you see after diuretics is definitely an improvement. But this is only on one, like this is just L1, L2. So it's curious to know, what about other regions as well? So this patient also had bilateral pleural effusions. So before diuretics, you can really appreciate the effusions that were there, versus post-diuretics now, not as much. So maybe there perhaps was a trace amount, but overall nothing as large as what there was before. Moving on now to the right side of the lung. So what was interesting here is, of course, we appreciate sort of B lines initially before diuretics, but then after Lasix, we can see what actually is more of an A-line predominant pattern, which really shows that sort of improvement with treatment. And then again, at the cost-of-running angle, before had effusion as well, but not so much when we look at it post diuretics. And so sort of one of the reason why I kind of wanted to point out this particular case is that, you know, I found it really helpful where you can really help use this as a tool to help notice improvement. And of course, you do want to look at other parameters as well. So for example, this patient, when we had initially POCUS, was on 5 liters of nasal pulmonary oxygen. And then by the time we had repocused, was on room air, was feeling a lot better as well. Weight was coming down. So there were definitely other parameters as well that was consistent. But what was also helpful to see that you could use an ultrasound as well, you know, to help provide that additional information for you as you're trying to help come up with your assessment. The other point that I really wanted to make in this this particular case is we've looked at what a pneumonia looks like, we've looked at what a complex effusion looks like, but I kind of wanted to touch base about what would like a cardiogenic pulmonary edema look like. And so top here on this clip here, you see what is a very smooth pleura with lots of B lines, and typically it would be in a bilateral distribution versus the unilateral nature of a pneumonia. And also it would start off more gravity dependent areas, and then as if it's worse, you would also see it up at the apices, and then of course you would see sort of bilateral effusions rather than sort of the more unilateral nature that we would expect, say, in an infectious process. And then here at the bottom is something known as the jellyfish sign, which you can often see when you're looking at sort of cardiogenic pulmonary edema, where the amount of effusion is larger and causes a compression and atelectasis on the lung. And so that's essentially what we're seeing here, and it kind of the tips of the lung are then just sort of flapping within the pleural fluid as well. So that was that. And then next one, the final case is a 71-year-old male with history of COPD and with alpha-1 antitrypsin deficiency, presented with progressive shortness of breath and anasarca. And the chest X-ray here showed that there was evidence of a moderate-sized pleural effusion. And this patient, however, was on 92%, just 1 liter of oxygen. And the question for us was, is there a large enough pocket for us to be able to tap and go ahead and do a thoracentesis? So starting off with, again, looking at the ultrasounds at R1 and L1, you can see clearly like A lines, but you can see a bit of sort of B line kind of trying to come through, but this is more now prominent in L2 and R2, where you can see sort of lots of sort of diffuse B lines. And then moving our way to the costophrenic angles, which is exactly where sort of the question lies, is, again, a thing that really jumped out is you can see that there is fluid, but then where exactly is the fluid? And so this is where kind of like what Mike was alluding to is, making sure you have your landmarks correctly is very important, and being able to identify the correct structure. So here we can see the liver, you can see the diaphragm, which is a hyperechoic structure, but what is really important is being able to trace the diaphragm all the way to the wall. If you look at the L4 image here on the bottom right, if you were to see any kind of hypoechoic structure and assume that this was the diaphragm here, you may mistaken the fluid over here as being fluid, as pleural fluid, when in fact, actually the diaphragm extends a little bit beyond that actually, and what you're seeing here is actually ascites, so fluid in the belly. And of course, this patient also does have a large pleural effusion. So, and then we were able to then verify it by then going into the abdomen and identifying that, yeah, this patient in fact did have pretty large volume ascites that can be tapped. And so really the important finding here is that being able to recognize using your landmarks, like where is the fluid coming from, and having a wide differential. When you see fluid in the lungs, is it coming from the heart? Is it an infectious process? Is it because your albumin is low, or is it because it's coming from somewhere in the belly because of ascites or cirrhosis? And so having those landmarks, so it kind of helps you avoid making an error in terms of when you're coming up with your assessment plan. And so in this particular case, we were able to share this information with the team, and then it was decided that it was important to actually start off with a paracentesis rather than a thoracentesis as they were initially planning, because we're worried that this is potentially a hepatic hydrothorax, and so by draining the chest wall, you risk the potential for it to just reaccumulate again unless you kind of address the large amount of fluid that's in the belly itself. So that was a really interesting case as well. So moving on to some of the limitations you might see in a chest ultrasound. So of course, the quality of scan is operator dependent, and your image acquisition is really important, because if you get poor images, then your assessment is not going to be within the right line. So for example, making sure your probe is perpendicular to the pleura, optimizing your depth and gain, making sure when you're scanning, if you get a rib shadow, you want to try to optimize your quality of your image, because sometimes a rib shadow, if it looks anechoic, you may think that it's fluid when in fact it's not, or misinterpreting a Z line for a B line. So it's very important that what image you get should help. If you have a good quality image, you can then form a good quality assessment. And so that's really important to understand. And the other limitation also important to understand is that when we're doing a lung scan, is you're assessing the periphery of the lung. And so if there is a pathology that's very deep or central, you may not be likely to pick up, because it's important where you place your probe. And that's part of the reason why we also do 4 different viewpoints, so we can try to pick up as much as possible. But there's always a possibility, of course, that there may be something that might be missed. So that's why putting everything within clinical context is really important. And then finally, to conclude, some of the advantages that we see with lung ultrasounds, as I was able to allude earlier, is that ultrasounds may be more accurate in detecting pleural fluid than a chest X-ray, as we saw given evidence as well in the meta-analysis as well. It helps provide very additional nuanced information than a chest X-ray might be able to. So for example, features of a non-translobar consolidation, helping identify complex effusion, and being able to even document certain improvement as we had seen. POCUS really allows you to provide really easily accessible, it's very easy accessible and real-time information, which is really helpful in helping the team, act quickly on their management plans. And also by having it as one additional tool available for you, it helps you determine, what, do I need a more expensive test, for example, like a CT scan, or does the POCUS ultrasound help you provide you the information you need and really helps you then choose wisely as well. And so I hope you found this helpful. It certainly taught me a lot, and definitely what I will continue to be using as a senior and in my respirology rotations as well. And so I'll close that off now and see if there are any questions.
That was great, Jen. Thanks a lot for that. You sort of highlighted a lot of the common stuff that we would see, and you did a good job sort of showing us some cool pictures with like normal and sort of abnormal stuff. So we've got a few people on the call. Does anyone have any questions or any comments or anything they'd like to talk about or bring up based on what Jen has presented?
Hi, Jen. That was a great
Hi.
presentation. Thank you.
Thank you.
I think there's a comment, really. I think you and Mike had alluded to this a couple of times in the presentation, that we really need to be scanning a patient's lungs at many different viewpoints. And the scans that you have shown us were 4 views of the chest on each side. Do you have any comments on other views or additional views, or any experience doing other views while you've been on the rotation?
I know that you can also, like, depending on if you're planning to tap someone, for example, there's like 0.5 and 6 as well, just posterior to the chest as well. And then the other thing really that's really important that I learned is when you get one viewpoint, if you're not sure about what you're looking at and you're not completely convinced, that you really got to like slide up and down or rotate your probe to really optimize your viewpoint. So for me, that was the biggest learning is, you never want to leave humming and hawing, because then you haven't really answered the question. So for me, that was my big takeaway was, just try to adjust your probe, adjust your settings as well on the ultrasound machine to make sure that, you have a good quality image. So I would say that would be really important.
I think that's a great comment about scanning the patient on their back, because the little historical foray into ultrasound in lungs that started in the ICU and emergency department. And these 4 zones that we typically scan for were chosen for the purpose of convenience, practicality, and I guess efficiency, because a supine ICU patient cannot be scanned on the back. An emerge patient, we want to screen for big diseases, and these 4 points are relatively convenient and efficient to use. Whereas, I typically find that with our walking wounded, so somewhat more ambulatory medicine patients, they're able to sit up, and the opportunity to scan their back, I think, provides a lot of additional information that you otherwise might miss, or it might add a lot to your clinical assessment as well. So I think that's definitely a good point, where if you have the opportunity, scanning the back could be potentially quite helpful.
Yeah. Perfect.
Yeah, no, I agree, and I think sometimes we have the benefit of sort of looking at the chest X-ray, whatever it is, and you just we sort of talked about this during our rotation. If you've got nice sort of normal A-line pattern, I typically what I will do is I quickly scan down rib space, and I may not clip that image if I've done my anterior lung zone, and I'll sort of move on. But for learners, I think it's important. You want to, just be a little bit systematic, and especially if you see something, particularly if you see something in that L1 zone, L2 zone, you don't want to just like say, okay, cool, clip it and go. You just want to like, well, what else is going on in that area, and try to capture as much as you can. So I think that's to get in. Once you sort of figure out the acquisition stuff, and it becomes more muscle memory, you know how to sort of fan the probe to be perpendicular to the pleura, then it becomes quite easy just to move down the lung and just sort of, take your clips as you go along. So, all right, Jen, thanks a lot. If there's no more comments or questions, will we get Kathleen to present her stuff?
Kathleen, I'm not sure if you're trying to talk, but we cannot hear you.
Well, can you hear me now?
Yes, we can.
Okay, sorry. Okay. Can everyone
No
see
worries.
my screen slide?
Yeah, can see it.
Okay.
Yep, they're
perfect. Thank you. Okay. So my name's Kathleen. I'm also a PGY3 completing my POCUS block with Mike and Zane. And today I'm going to be talking about a case that I think very well demonstrates how point of care ultrasound is becoming the new stethoscope of medicine. So to start off with our case, we had an 84-year-old gentleman who was transferred from Ingersoll for consideration of new start dialysis in the setting of an AKI. He previously had blood cultures positive for Streptococcus mitis and was receiving IV antibiotics of ceftriaxone. An echocardiogram performed in Ingersoll was concerning for query infective endocarditis, and I have the report listed below, but as it mentions, there was nodular thickening of the aortic valve cusp, which could be in keeping with a chronic vegetation or thrombus. Past medical history-wise for this gentleman, he had a known history of aortic insufficiency. He had prostate cancer with bone metastases, right hip arthroplasty, prior exposure to Hep A and B, and spinal stenosis. On presentation to the emergency department, you can see his vitals listed here, but he was hemodynamically stable, afebrile, but notably on 4 liters of oxygen setting at 92%. And here's his chest X-ray on the right. Relevant investigations for him, his creatinine was 465, when previously in July had been around 96. There was no metabolic abnormalities, and he had good urine output of 1.1 liters over the past 24 hours. Notably, he did have a low platelet count, which the MRP team at that time was wondering was related to a drug reaction to ceftriaxone. 1 week later, however, this gentleman's O2 requirements increased up to 10 liters per minute, and the team rightfully so ordered a CTPA to rule out a possibility of septic emboli. There's no evidence of pulmonary embolism, no septic emboli, but what the radiologist did comment on was bilateral ground glass opacities with a broad differential including pulmonary edema, infection, organizing pneumonia, and drug reaction. And so with that information, it was difficult for the MRP team to decide where exactly to go in terms of the management for his hypoxia. And that's where the POCUS team came into play. The question they had for us was, what was the cause of this patient's hypoxia? And so Jen has nicely sort of laid the foundation of lung ultrasound, so I won't be going through the details, but just to orientate you quickly, on the right, you can see this is the right side of his lung. This is the left side of his lung. And currently we're looking at the anterior chest wall, noted by the red X's on the figure. And so what I'd like to draw your attention to is that you can see in all 4 of these lung views, there are confluent B lines, but the contrast between the right and the left side is that on the right side, you can see this nice, smooth, shimmering pleura. And then on the left, you'll notice it's very irregular, and there's sort of this subpleural consolidation that's possibly concerning for an infectious etiology. Moving on to the lower lung fields, just click it here, right side, left side, and we're looking at the orange X's on the figure here. When you look at the left side, you can again see a pleural effusion here with a consolidated lung tip coming in and out of view. And then moving on to the right, again, you're seeing a moderate to large pleural effusion with that consolidated lung tip moving in and out. But what I'd like to draw your attention to is that you'll notice that there's a bit of graininess to the pleural fluid. And we probably could appreciate this better at the bedside, but what we were thinking at the time was that this was related to what we call a shred sign, which was indicating some complexity to the fluid there, indicating a possible infection. And so based off of our thoracic findings, what we could comment on is that there's bilateral interstitial findings with both basal and anterior consolidations with a moderate to large right-sided pleural effusion. And so we were wondering, could this be infection? Could this be inflammatory? Could there also be pulmonary edema in this gentleman? And it was a little bit difficult to say. And so to gather more information to help address this question, we then moved on to the cardiac POCUS. And for those of you, I'll just move this out. For those of you who are less familiar with cardiac POCUS, we'll just go over it briefly on acquisition. But currently we're looking at the peristernal long axis, and you place the
sorry, hey Kathleen, do you mind maybe switching off your video? I think just there may be a lag there.
Yeah, no problem.
Yeah,
Is that better?
That may help the image.
Is that better?
Rather.
Is that better, Zane?
Oh, your video is still on.
Oh, my video is still on?
Yeah, I mean, I'm just wondering if you turn off your, I don't know if it's an internet issue because like the clips are a bit laggy.
Is that better? Well,
it's kind of frozen now.
I can see the images fine on my view.
Yeah, hold on.
Maybe it's my internet.
Hold on a second.
Maybe if you go, maybe restart the.
Yeah, okay. Let me try again. Sorry about that.
That's okay.
Okay. Let's go back. Can you see my screen again?
Yep.
Yep.
Okay. Is that working now?
Yes, I can see it move.
Okay. Okay. Sounds good. So just to go over acquisition quickly, we are looking right now at the peristernal long axis, and on the figure, on the upper right figure, you can see here that the probe is placed on the anterior chest wall with the probe marker facing towards the right shoulder. And here on the bottom right is a scan of the normal images or structures you'd be expecting to see. And so when we go to the scan that we obtained at the bedside, I'll just draw your attention to some of the abnormalities we immediately noticed, but the LV looked quite dilated. And using the rule of thirds where you're comparing the RV, the aortic root, and the LA together, the aortic root looked quite dilated in comparison to the RV, and maybe there was some dilation of the LA at that point. Drawing your attention to the normal peristernal long axis picture here, you'll notice that the aortic cusps are quite thin in the imaging. But when you look at our image as well, they're quite hyperechoic or isoechoic, and there seems to be some sort of density on the valve that we wanted to take further looks at. And so on POCUS, one view is no view, so you always have to obtain more views. And so moving on to the peristernal short axis, where you're keeping your probe at the exact same position, but rotating at 90 degrees to face the patient's left shoulder. This view is great when in terms of assessing the patient's LV in terms of function. And so here, if I place my marker in the middle of the screen, you can see that the LV cavity is contracting equally in all wall areas. Getting a better look at the aortic valve, keeping your probe in that exact same position, but tilting it towards the patient's head, you can actually bring out the aortic valve. And this view is great when trying to determine if a patient has a congenital bicuspid valve versus tricuspid valve. And here again, I'll just point your attention to this bright density located on the aortic valve. And we'll come back to that in a bit. And so this is called the apical 5 chamber, and you just slide your probe down towards where the apex bead is located, and the probe marker is pointed towards the 3 o'clock position on the patient's left. And this view is optimal for looking at all the ventricles, all the atria. And what it also is great to view is the aortic valve along with the aortic outflow tract, or the LV outflow tract. And so for time's sake, I'll just point out the main abnormality that was seen initially when he was being scanned was this vegetation, or this isoechoic hypermobile density located on the aortic valve. And so when we saw this, we were highly concerned that this patient had infective endocarditis as advertised from Ingersoll. And so this is just another image of the scan that was obtained. And again, you can see that isoechoic density moving around and sort of flapping with the blood flow. And so based off of our cardiac findings, we were concerned that this patient had a isochoic density located on the aortic valve, concerning for infective endocarditis. But otherwise, just taking in all the scans that we saw together, we could say that the LV systolic function looked normal, although the cavity was dilated, and the aortic root was quite enlarged. And so with this patient's hypoxia, with the possibility of an aortic vegetation, and with this dilated root, we were quite concerned that this patient was having aortic regurgitation of significant degree. And so I think all of us as physicians, the tools that we have at the bedside when we want to try and determine whether or not a patient has aortic regurgitation prior to the onset of POCUS was physical exam. And so I think a lot of us can say that we're not always comfortable making clinical decisions based off of what we hear in auscultation. So it's very important that POCUS is being incorporated more into care, because it'll help to bridge that gap where physical exam maneuvers may not be able to help immediately identify a significant valvular regurgitation. And so the way that POCUS allows us to identify these valvular regurgitations is through color Doppler. And so just briefly covering what color Doppler is, it's a main assessment for rapid assessment of valvular regurgitation. And bringing you back to high school physics, where we talk about an ambulance siren and the changes in tone when it's coming towards and away from you, color Doppler utilizes a similar thing, where the ultrasound probe shoots out waveforms and then bounces back towards the probe based off of the flow of blood. And so the acronym that many people use is blue away from the probe and red is towards the probe. And the brighter the color is, the higher the velocity is. And the best way when you're obtaining color Doppler is to have the probe angled parallel towards blood flow rather than perpendicular. And so going back to our cardiac POCUS exam, you can see here we flew through color Doppler over the aortic valve. And what you can see here is a confluence of color indicating significant regurgitation of the aortic valve moving into the left ventricle. And then moving on into the peristernal short axis, we can again see this confluence of color indicating significant regurgitation. And then lastly, going back into the apical 5 chamber, just reconfirming that we're seeing significant turbulent blood flow. And so I'd like to draw your attention to the fact that in this confluent jet, you're not just seeing blue or red, you're actually seeing all colors of the rainbow. And what that's indicating to us is that the velocity of blood flow is so high that the machine is unable to calculate whether it's moving towards or away. And so what we knew based off of our bedside POCUS exam is that this patient was having significant aortic regurgitation. But in terms of trying to quantify it as moderate to severe, further calculations and assessments would have had to been done at the bedside. And so we won't go into that today, but I have listed here for you some of the common things that we can do at the bedside. And the most common ones that would be utilized are in bold here. And so based off of our 2D findings and Doppler assessment, we were concerned about at that time of significant or acute aortic regurgitation in the setting of infective endocarditis. And as many of you who are here studying for the Royal College know, when you have infective endocarditis with concerns for valvular dysfunction or signs or symptoms of heart failure, that is an class 1 indication for surgical intervention. And so we very quickly communicated our results to the MRP team so that a comprehensive echocardiogram could be performed to further delineate the severity of the lesion. And so tying this back to our thoracic POCUS that we'd seen where our differential was still infectious inflammatory versus pulmonary edema, with the degree of aortic regurgitation that we were seeing at that time, it was safe to say that there's definitely an infectious component, but possible concurrent pulmonary edema contributing to this patient's hypoxia. And so later that day, a comprehensive echocardiogram was obtained, and these are the results. But just to highlight your attention, this patient, the report did comment on a severely dilated left ventricle with a normal EF. There was severe aortic regurgitation, which was similar to what we had said. But surprisingly, they had said no grossly thickened aortic, or they said no associated mobile echo density. And so what I'd like to remind people is that point of care ultrasound, when we're taking these images, is essentially a snapshot of a patient at that time and place. And so every image that we take after we take, or every time we take the probe off that patient's chest, we're going to be seeing the patient at a different time course in their care. And so we're always acquiring new data points to that patient's case. And so outcomes for a patient case, after the results of the echo were obtained, the MRP team had a goals of care conversation with the family regarding whether or not they'd want to pursue surgical intervention for the aortic regurgitation. And it was opted at that time that he would be for medical management. But given he had ongoing hypoxia, the team did aim for further fluid removal while undergoing dialysis. And currently he's on 1 liter of oxygen, so doing much better. Given that he had 2 point of care ultrasounds demonstrating this isoechoic density, he did complete a 6-week course of antibiotics for infective endocarditis. And so just to go over the benefits of POCUS, one of the main benefits is that point of care ultrasound, as I mentioned before, is dynamic and something that you can do easily at the bedside. So for example, if this patient's oxygen requirements had actually increased rather than decreasing with time, it would have been very beneficial for us to go back to the bedside and be able to rescan his lungs and see what changes had been occurring in comparison to the time when we had scanned him. And that would have allowed for better management for this patient. The other thing as well, going to the fact that this patient had acute aortic regurgitation, is that it allowed for rapid assessment and attain of the formal echo, along with possible consultation of a surgical service if this patient had opted for surgery. And so I think this case really highlights the utility that point of care ultrasound can have when providing good patient care in terms of accurate management plans, along with providing rapid assessment. And so to conclude, I think similar to Jen, I've learned so much over the course of this 4-week rotation. And as I move on to blocks where I'm senioring and taking care of lots of patients, I can definitely say that for more difficult patient cases, I will have a lot of more sense of security on what I'm doing for the patients with POCUS as a tool in my kit to use. Thank you.
All right, Kathleen, thank you. You can turn your video back on if you like now. Thanks for that. That was a very interesting case. Was obviously scanned multiple times, both formally, I say formally, I mean sort of by an echocardiographer or tech, and I was at several sort of points in their clinical course. So it's quite interesting. I think the initial scan, I think was done when the patient, I think, had just showed up, and I think it was done by Aaron. Aaron, I think you're on this call. Is that right? Yeah, Aaron. So maybe you could sort of, comment on. I think that case was reviewed by Jeff, and then I think you and Mike sort of scanned that patient. I think maybe a few days sort of down the road. So what did you guys think, Aaron and Jeff? Because obviously there was a difference in the scans there, right? With the sort of what clearly looked like a vegetation to me, and then when Kathleen and Mike scanned, and really couldn't notice anything. So what do you guys think about that?
Maybe I'll let Aaron comment on most of it, but I agree with you. When I saw the scan at the beginning, I thought it was quite clear there was vegetation, especially in the clinical setting with streptomyces.
Right. Yeah, and that to me, and I'm sure Mike can sort of weigh in here. I mean, that's I would call that a vegetation all day, every day. And then, but if we hadn't seen this, right? If you guys hadn't done this report, this echo, and they had the sort of echocardio, the sort of tech do the echo, and that report just said, well, the aortic cusps were thickened. That patient, I guess, would not have been treated for infective endocarditis, right? So I think that's the sort of big take-home point for me here, is that so something happened to that veggie, probably embolized. But I think that was the big take-home for me, is that the scan that was sort of first done, it just sort of really changed the change the sort of treatment course for this patient.
I don't think at the end of the day, Dane, that it did change much. I think the patient was already 5 weeks in or something of the sort to because they had started their antibiotics in September in Ingersoll. But what I think that was important was to consider that there was potentially cardiac decompensation. So if the patient already had aortic regurgitation, and antibiotics are only so good when it comes to treatment. There's still some sort of damage that probably led to worsening severity of the aortic regurg, which may have been what kind of led to the decompensation to a certain degree clinically, because obviously based on Kathleen's scan there was more than just volume overload. There's more than just pulmonary edema that can be attributed to heart failure and aortic regurgitation. I think it just gave the team a bit more information as to, okay, we should actually know whether or not, there's a cardiac contribution to things going on, because to that point, I don't think that had been strongly considered. Correct me if I'm wrong based on your clinical kind of gestalt, Aaron. I think you're on the call and you were looking after the patient.
Yeah, I think it was a bit tricky because when we admitted the patient, when looking back at all their echoes over the past 5 years, there are sort of differences in the reports on how severe the AR really was. I think back in 2015, there was a report saying severe AR, and then later on said moderate AR. And the report from Ingersoll wasn't, I think, it didn't really comment too strongly on the severity of AR and whether or not there was a vegetation. So doing the multiple POCUS scans and the comprehensive echo later on during imaging really kind of helped in quantifying how much valvulopathy there was and giving us more information to come to the family and say, you know what, we know it's much worse than before. Should we consider surgical management? And that ultimately helped with the goals of care discussion.
Great. Well, that was a great case. Does anyone else have any comments or questions or anything?
Actually, I might just add as so hi everyone, I'm Drew. I'm one of the POCUS fellows over on the ICU side. Kathleen, I'm wondering if you wouldn't mind bringing up your presentation one more time and just go into that apical 5 with the color Doppler on it.
Yep.
Just wanted to throw in a little commentary on just some potential pitfalls.
Okay. Sure. This one. There's
and mainly just that I mean, it's fantastic talk and like really great images. The color signal that you have shown on there.
You want the, sorry, let me do that one.
There you go.
There we go.
And as you had pointed out, like that just sort of like washing machine, like all the colors are present simultaneously, indicating that you're sort of above the threshold at which the machine can measure. One thing for anyone who's going to start applying color Doppler for valvular assessments is to just always pay attention to what the numbers on that scale on the upper left-hand side of the screen are, because you can create this same effect by just having the scale too low. And for whenever you're placing color Doppler to assess sort of visually the severity of regurgitant lesions, optimizing that for cardiac assessment, having it at least in the sort of above 55 and ideally into the 60s and maybe even the 70s, really helps to clean up those signals. And for purposes of classifying the severity of AR, the severe is 65% of the LVOT, and having that set to the highest possible threshold can give you sort of a cleaner sense of how much of the LVOT it's taking up. That was my only little comment. Otherwise, great.
Thanks, Drew. Much appreciated. Glad that you guys could join. I will also say that the TE7's cardiac mode is not as robust as the M9. And if you make this box this size, it can only, like, it won't give you a nyquist usually above 50 or so. And if you make the box a little smaller, you might get to like the 58, but it doesn't go much higher.
Oh, that's unfortunate.
That is one of the limitations. And obviously that limitation can be addressed by doing other more complex and quantitative things, which Kathleen did at the bedside by putting continuous wave Doppler through it, and verifying what you see visually. But that is beyond the scope of what we generally do, and so we wanted to, I think, keep this to 2D and color Doppler discussion. But you make a very valid point.
All right. Well, I guess that's it, guys. If no one has anything else to add, thanks a lot for joining, and hopefully we can do more of these. Looks like we have some rotators over the next few blocks here, so we'll try to hopefully organize more of these, and you guys are sort of welcome to join and sort of partake in this discussion. I hope you guys found this valuable, and yeah, go forth and happy scanning.
Thanks, Jen and Kathleen. That was great.
Thank you.
Great talk, both of you. Thanks.
Thanks.